Good morning, everybody. I'm Patricia Marsh. I'm a regional advisor for healthy aging at PAHO. And I welcome you to this seminar in the region of the Americas for healthy aging here. And this document, the document about our subject of today, is a gateway for improving the care of the elderly so that the people who live in have who are dependent on care receive the appropriate care. And the document is available in English and Spanish, and soon it will also be available in Portuguese. Before we start, I wanted to tell you that we have simultaneous translation in Spanish, Portuguese, and English. You can choose your preferred language by clicking on the lower part of your screen. And uh, we remind you that this event will be recorded and that it will be available at the webpage of PAHO.
And invite her to share her opening remarks. Dr. Celia, the floor is yours.
Good morning, everyone. Thank you, Patricia, for that very warm welcome. And I want to say good morning to all the over 100 participants I see joining us online. Also, good morning to and recognition to Dr. James Fitzgerald, the Department Director of the HSS department here in PAHO at Washington, D.C., and members of his team as well. It's my great pleasure to welcome all of you to today's webinar on long-term care for older people, a set of interventions for universal health coverage. We are honored to have the participation of technical delegates from the Ministries of Health from Brazil, Costa Rica, Chile, and also an expert from Canada. We are also joined by representatives of international agencies, including the Inter-American Development Bank, the International Labour Organization, and the Organization for Economic Cooperation and Development. In addition, we are also pleased to welcome and anticipate the participation of Dr. Hang from WHO, with the support of PAHO colleagues contributing to the development of this event. Your presence reflects the shared commitment that brings us together today. In the Americas, life expectancy has increased significantly in recent decades, reflecting the tremendous progress of our societies and health systems. Yet, this success has not been matched by an equivalent rise in healthy life expectancy. Millions of people are living longer, but they're living with disabilities or dependency on others. While dependency can occur at any stage of life, today, in this webinar, we will focus on the long-term care needs of older persons. As functional ability declines, the demand for long-term care services grows, and with populations aging, that demand is rising rapidly. In 2020 alone, at least 8 million older persons in Latin America and the Caribbean required long-term care. By 2050, this number is expected to triple to 23 million. At the same time, the supply of unpaid family care, on which our societies have long relied, is shrinking. This growing burden on caregivers continues to largely fall on women, deepening gender inequalities. The implications of this situation are profound for health and social protection systems, for economies, and for societies as a whole. In 2022, the cost of financing long-term care in Latin America and the Caribbean was estimated at an average of 0.27% of GDP under a low coverage scenario, defined as reaching only 35% of people aged 65 and over who require such care. This figure is projected to rise to 0.77% of GDP by 2050. These estimates highlight the urgency of investing to ensure access to long-term care and disability prevention across the life course. This is why the adoption of PAHO's member states of the Regional Policy on Long-Term Care at the 61st Directing Council was so critical. It is why today's launch marks a concrete step forward to support member states to translate their commitments into action. The new WHO document, Long-Term Care for Older People, Package of Interventions for Universal Health Coverage, offers a pragmatic, evidence-based framework adaptable to local contexts. It emphasizes the need for integrated, person-centered services that combine health, social, and palliative care while supporting caregivers and strengthening the workforce. It aims to build inclusive, sustainable, long-term care services that support older people while advancing universal health coverage. This effort is fully aligned with the United Nations Decade of Healthy Aging, which calls on us to act now to create societies where people not only live longer, but also live healthier, more dignified, and more fulfilling lives. Strengthening long-term care is indispensable to realizing this vision. As we begin today's program, I wish to recognize the progress already made by our member states and the collaborations established with international agencies and partners. Building resilient health and social protection systems that include long-term care requires the coordinated efforts of governments, communities, and the international community alike. It also calls for strong support for caregivers, a well-trained workforce, effective governance, and sustainable financing, and above all, an unwavering commitment to the dignity and needs of all those who require care. I am confident that the knowledge that will be shared today will inspire bold and practical steps forward. Thank you once again for your commitment, and I wish all of you a very productive and inspiring exchange. Thank you.
Thank you very much, Dr. Sally Thomas, for underlining the importance of strengthening long-term care in the region of the Americas and the role of PAHO in supporting member states. It is now my pleasure to invite my colleague Hyobong Young, Medical Officer on Long-Term Care at the WHO headquarters, to present the document we are launching in our region today. Hyobong, you have 10 minutes. The floor is yours.
Thank you so much, Patricia. So I'm now sharing my screen. Can you see that?
Yes.
Okay, thanks so much. It's my great pleasure to be here, and congratulations for organizing this webinar to introduce the package document. So as introduced, my name is Hyobom Jang from WHO headquarters in Geneva, Switzerland. Many of you have heard about the UN Decade of Healthy Aging, which is from 2021 to 2030. And since that year, WHO with other UN agencies and international partners have tirelessly worked on to implement the action areas. We have 4 action areas starting from ageism to environment and providing interior care and long-term care for the people. And now until the 2030, which is decade is ending, we are aiming to implement our support and actions to be implemented in the countries as we support. So long-term care has been part of the concept of healthy aging by WHO since 2015, where the World Report was first published. And then in this report, the healthy aging concept of preserving interest capacity and maintaining functional ability have been introduced. So the long-term care by WHO means is that for all the people who have already lost some level of interest capacity, the long-term care is to help them to maintain functional ability and then provide some level of care and support and then with the environment. And this importance of long-term care has been captured by the UN Decade of Healthy Aging, which started in 2021 as a 4th action area. Since then, WHO has worked with partners, including our regional colleagues in PAHO, to provide technical guidance. 4 years ago, WHO published a long-term care framework to help countries to assess and strengthen long-term care, and the current one, UHC package. Now, WHO is working to develop global standards for long-term care the next 2 years. So what does long-term care mean to the government? The health sectors and ministries may not feel familiar as if they consider long-term care as a responsibility of the social sector. But we ask to imagine beyond the traditional UHC concept. If we think about the UHC concept, we have three dimensions. We have we want to provide service coverage for all the population, but we have to ask ourselves if the services are all covering the needs of meeting the needs of all the people and their family carers. And also, not only for healthcare services, if our coverage is also on the social protection, which is the core component of long-term care, and then also not just providing services as it is, but try to provide a continuum care and integrated person-centered care in a new future health system that might be the goal of the countries. So this package aim to help countries to assess the systems, what kind of services interventions they have, to see what kind of interventions could be introduced and then implemented as part of their essential benefit packages or UHC compendium, and then for countries and health and finance ministries to allocate resources to implement and provide those interventions, and eventually also to provide support and capacity building opportunities for health and care workers in the long-term care with some list of education and training programs for them, as well as recognize the importance of those unpaid informal family carers and then ensuring services to be provided for them. So what is the package? Inside the package, we have identified the core interventions with the three categories: interventions to assess and address healthcare needs, palliative care needs, and social care and support needs. And then we have also identified facilitating factors to implement this approach, which are person-centered care and education and training for long-term care workers and carers. We have also set examples of across the care settings from home, daycare, and community centers to assisted living and residential care facilities. And also we have provided relevant country examples in the package. There are many and various actors involved in the long-term care. We can imagine they are professional workers like health workers or medical or social workers. But if we expand the spectrum, there are also volunteers, friends and families and neighbors, friends, and also partners who are more likely be considered as a carers. They are sometimes called informal caregivers, unpaid carers, or care partners. So what's inside the package? For each interventions for UHC, we have provided the descriptions, what is the need for other people, and what could be the assessment strategy, and what would be the management measures. And there are key points that readers could easily identify and consider, and there are more specific action points that the long-term care policymakers, administrators, long-term care managers can implement at their relevant levels. So let's look at the first category of core interventions, which is interventions to address healthcare needs. You can imagine those interventions are very relevant to meet the care needs of older people, like a cognitive decline, mobility, falls prevention, pain management, and then we are aligning with our WHO's framework on integrated care for older people and providing these interventions in the UHC Compendium WHO, that those interventions can be used to screen, assess, and manage older people's needs. And there are also palliative care needs, which has been acknowledged by our partners in palliative care that the long-term care interventions included those important interventions. And the final category is social care and support needs, which is sometimes linked or separated or fragmented in countries depending on the settings. But basically, they are social and personal care, assistive care to support older people's needs in daily living and their accessibility assistive products. Importantly, we try to also include the core interventions for not only older people, but also carers, like providing psychosocial support and respite care for them. And there are some facilitating factors which many of you might be familiar that long-term care should follow the person-centered interview care process, starting from a needs assessment and developing a comprehensive care and support plan, and that should be coordinated by the interdisciplinary team in the community level. And we also provide some list of training topics for not only professional care workers, but also unpaid carers, that those could be the minimum list of topics that workers and carers are expected to receive. And then we have also provided some steps of implementation, and then the policymakers and implementers can follow these steps easily. We also highlighted one important principle that older people and their carers should be engaged in the implementation process to hear their voices, to hear their preference goals, and they are provided a meaningful, sustainable dialogue and empowerment in their communities. So what will be the next steps for WHO for the next few years? As mentioned, WHO is currently developing global standards long-term care. We are working to provide capacity building resources for carers and care workers. We are supporting and working with the countries to build policies and services for long-term care. And we are exploring and to generate evidence for community-based models. And eventually, by the end of the UN decade, we will be able to provide a global standard support on long-term care. So yes, we can make long-term care happen and real in the countries. Governments can adopt and finance a national long-term care policy, and they can define a standard long-term care benefit packages. And of course, they can invest more in the care workforce, including supporting carers. And of course, the focus could be more on home and community-based care rather than institutional level facility care. And we always encourage governments to engage older people and their carers. In all this process, WHO can provide tools like a national care assessment and support the implementation and facilitate peer learning between different regions and countries. Thank you so much.
Thank you so much, Yobon, for this comprehensive overview of the set of interventions that countries may prioritize and integrate long-term care into their health and social protection systems. I would like to invite everybody here at the webinar to access the document. It is available in Spanish and English at our Healthy Aging website. The link is on the chat, and we are working on the Portuguese version currently, so it will be available soon. I'll switch to Spanish.
So now we will start with a panel with representatives of different countries of the region who will share with us how they are developing long-term care packages in their countries and the progress achieved and the needs they have. I remind the panelists that you have 10 minutes for your respective interventions. And the first person would be Alicia Santos Roberto uh, from Brazil. Alicia, you have the floor.
I would start off by inviting the Brazilian representative to present the work she's been doing for long-term care. I'd like to thank you all for your invitation, Patricia, specialists who are here with us today. I'll be sharing my screen. Can you see my screen? Yes, we can. So my name is Ligia Yasmini. I'm a family and community doctor and a specialist in geriatrics, and I coordinate healthcare for the elderly population at the Brazilian Ministry of Health under the primary healthcare attention. I'm so sorry I started speaking too fast. I'll try to speak a bit slower. In Brazil, we have reached over 35 million elderly people, over 16% of the Brazilian population. This is a progressive movement, and there are always challenges that have to do with a decrease in families and the demographic increase in a country as large as Brazil. Brazil is aging very quickly, but also unequally. The population in the southeast region is more elderly, and the north region has only 10% of people over 60. In Brazil, we consider that the elderly are elderly over the age of 60. There's also the feminization of aging that directs our efforts to improve the social organization of care, since the elderly generally are also women. There is a large percentage of elderly with activity limitations in their daily lives. A nationwide study that we conduct is called the National Healthcare Study, which has led us to the following numbers. 20.4% of the elderly people face some kind of limitation to their daily lives. And there is also a skewer in the access to services, income, and also a difference in terms of race, color, gender, and the higher age groups. The more elderly, the more dependent on care. Brazil has a series of normative milestones, policies that are expedited by the Ministry of Health and we also created an activity called the Decade of Healthy Aging, uh, which considers offering long-term care to those who need it. When you speak about healthcare systems, the idea is the purpose for our national health policy for the elderly. Its purpose is to recover, maintain, and promote the autonomy and independence of elderly individuals based on collective and individual comprehensive care measures that strengthen the principles and executive boards of the unified health systems. This is aligned with the principles of universality, equity, and integrality, but it also needs to be run alongside our unified healthcare system, social assistance system, which is a recent system and it is under consolidation as we speak. And when we consider some of our challenges, this is where ensuring capillarity, structures, territorialization, and this has to do with several institutions for the elderly, such as hostels, homes, and answering the basic social protection at home for people with disabilities and the elderly guidelines. So this is not something that is needed for the future. This is something we need to move forward with urgently, articulating healthcare and social systems to ensure that the territories understand the needs of the elderly from a person-based centered perspective. The home care system in our unified healthcare is active. There are three modalities. Firstly, the Living Better at Home program, which offers home care and specialized care for the elderly, in which teams go out to the person, whether in their homes, in caregiving homes, but these are people who need intensive care. That is, on a weekly basis at least, and complex, that sometimes is higher than what the primary attention mode can provide. So this is one of our home attention program services, which has today reaches over 2,000 municipalities in Brazil. The National Palliative Care Policy has been recently instituted, and the idea is to qualify access to those who need or require this type of care, and a special highlight to the community workers, which is important for identifying those who need this type of care. So the family healthcare strategies and the third line of care, family health strategies, is the multidisciplinary teams to provide comprehensive health care longitudinally from health promotion to rehabilitation. We already have over 102 million home visits from January this year till today, directed at elderly population. So this is the very core of our longitudinal strategy. The multi-professional teams are also included in the primary health teams. They act as a complement, and they act in tandem in long stay institutions, territories, and other locales. There are a few strategies which are being taken up once again. For example, the Elderly People's Health Book, the digital passbook, to integrate data and information throughout our whole healthcare system. The electronic health record this year included an index of vulnerability in this electronic health records, which helps our team to identify some prevalent conditions such as alterations in humor, cognition, aspects in intrinsic capacity, and others. The Programa Farmácia Popular, which offers diaper care for the elderly, free of charge, and also a few medications that are focused and important for the control of chronic diseases such as diabetes for the elderly population and hypertension. We'd also like to highlight long-term care for the elderly, a few successful municipal experiences. Carla Jacobini is here today. I believe Dr. Peter is also in the seminar today. He's also a WHO partner. And this is important in terms of intersectoral coordination. The idea is to effectively articulate our activities, and we hope that the National healthcare policy, and the National Plan for the Rights of the Elderly, which is supposed to come into effect this year.
You, Alicia, for sharing this experience in Brazil and highlighting this long-term care for the elderly.
Now I invite Dr. Avalos to Alejandra to give us her presentation on her perspectives on the country. Good morning and welcome to this presentation. In the outlook of primary care, we are seeing a great challenge in long-term care. Today in Chile, we have a advanced demographic transition, and we have about 1.5 children per woman, a life expectancy over 81 years of age, and 14% of the population is above 65 years, and this is becoming the longest stage of life. And we have this life expectancy that is above 81, that is marked by aging, women that have 85 years, some with 78. We have the importance here of a network of health that helps us in the whole national territory. We have more than 2,663 facilities. We have a lot of rural surface, but we have more than 1,100 rural facilities around the country. And we have a public insurance and a private insurance, which is FONASA, that is a national health fund. They are the ones that are in charge of the public insurance, and they service 85% of the population in Chile. And we have a relevance in terms of addressing most of this population that represents, in terms of elderly people, 92% within this insurance. The population that is 60 and above between primary care. And this means that in terms of beneficiary population in the Chilean health system, we have 21% of this population that is registered in the facilities around the country. So how do we organize ourselves as a country in care to be able to deliver this care? And first, we have intersectorial work with many ministries through different actions through the Ministry of Health. In primary care, first we have the comprehensive evaluation. This is a preventive medicine test or exam. This is something that is given within family care to all people that are beneficiaries in primary care. We also have controls. We have a program that does prevention, and we start at early stages for older people. And we have, I'm sorry, I lost my train of thought there. Says Alejandra, we have programs for healthy living, and they address people from childhood to 65. Then we have the older adult, and that has they work on therapy for functional activities, and this is a program that delays dependence processes, we have a comprehensive rehabilitation program that is focused on dependents that have moderate pathologies such as chronic pain. This also includes a significant number of population, and it includes the care avoiding more severe dependencies. We also have a program for severe attention, and we are not just addressing severe dependence, but also the families that fulfill these roles of care, mainly the women who are in charge of this care. And therefore, we have a strategy for comprehensive care focused on people. And the vision is not just for the person, the other person, but the family and the community. And a few years ago, we had a strategy for universal care, and they leave the second and third levels of care and they go to primary care with the purpose of not just providing care to people that in the last moments of their life regarding cancer and other terminal illnesses, but they also accompany all people that require it. Since 2023, we began a process of reform in primary care. This is the universal APS, where we're going to try to get not just universal coverage for all people that are part of the territory, but also being able to provide a certain coverage and intersectorially to do work that is to do joint work with other ministries, such as the Ministry of Social Development and Family, where in the last period we have also implemented a national care system that is there to strengthen cross-cutting care for people in different areas. In terms of the hospital area, we have some strategies that are also important when we talk about long-term care, such as telecare that has multidisciplinary teams supporting primary care, and they have specialized tools to have advanced care. We have social sanitary beds in the hospitals that help us provide more specialized care, and it is for people who do not have a support network that provides permanent care. We have technical aid that is guaranteed by the state for people that have certain levels of dependence, and we have a law called Ricardo Sorto that provides home deliveries of medications and others so that we can provide the necessary care. We are now updating the long-term stay sites. These are the LIAMs, where we went from Decree 14 to Decree 20 that allows us to have a level of financing that the Ministry of Planning, the one that does construction today in the country, supporting the Ministry of Social Development through the National Service of Older Adults, produces or builds establishes these facilities for older adults. We already have 22 in Chile, and they have high standards in the number of professionals and the care that they provide. Given that, through this degree, we determine the number of professionals and the number of caretakers that these spaces should have, depending on the level of dependence, and this would include day and nighttime care. We also have about 1,400 LMs, or private care centers, that are operated in coordination with the National Service for Older Adults, but all of them, without exception, are part of the primary care network, and all of these people are beneficiaries of primary care, and therefore they have health care and family care guaranteed and other social controls, for example, with the delivery of medication for chronic illnesses, and if necessary, be part of that primary care. We have work that we are working very closely with the Ministry of Social Development, where we have guarantees such as the universal pension for older persons, today we've also had a reform in this, and this week we were able to celebrate the increase of that subsidy for older people, people over 84, and every year we are working on exiting poverty in terms of pensions. We also have a local network for care that works together with primary care that helps us integrate the care of caretakers and some multidisciplinary care with physical therapists, psychologists, and others, and provide all of this in the home for the people that require this care. And then some other actions with the Ministry of Labor, for example, where there are profiles and certifications of certain skills so that we can have formal caretakers that can belong to this network, and actions that are meant to raise the standard of care, such as a cross-cutting need that goes beyond the actions that can come from the Ministry of Health. So intersectorial work right now is one of the most important pieces of work that we have done. Now, regarding more specific advances, this is what I was saying. We have a strategy in the health network and the implementation of different strategies. And this is what I was saying previously. We have a diagnosis and regulations. And here it is important to see that we have interoperability amongst each one of the services. Today we have a platform that is local social management that allows us to know about social actions within the municipalities in each one of the communes in our country, and they are able to visualize in a health module all the actions and benefits that a family or person is receiving, and it identifies the network of caretakers in that space so that we can prioritize certain healthcare actions. Today we have a preferent care law, and this allows us to provide priorities to people who have disabilities, older people, and others. We have a HIS. This is an explicit guarantee from health that is aimed at dementia, where a person that has a physical disability may not necessarily need care. We also know that there are other types of needs regarding care, so it recognizes caretakers of people with dementia at different stages, and they become part of the network, and they can go to the primary care programs that allows them to access the benefits in the network. Then we have a record of long-term facilities. We also have a record or registry for long-term care providers in the Ministry of Health and also in the Ministry of Social Development. And we have updates or decrees that are regulatory in nature. We have the connection of primary care and then support and care programs. And we have the recognition of people with dependents and their caretakers. We do this through economic support. These are stipends that are coordinated amongst both ministries, and we are advancing on this national system for care that is both based in health and the social aspect for each one of the local spaces. And therefore, intersectoriality is not just happening at the higher levels, but it's being landed in lower levels so that we can help that population. And last slide. The challenges that we face today in terms of long-term care in Chile. Well, first, to update certain actions within the legal financial network. Today we are working on a bill to protect older people. We want to improve certain actions in the territories, especially in rural areas. We have some preventive actions there, and we also want some promotion in that area. We want to continue improving connections amongst institutions to create complementarity amongst the strategies. We also want to have greater participation that is centered in older persons, and we want to develop skills in the teams that are directly managing and providing care to these older persons. And we do this with a cross-cutting line regarding how to reinforce this promotion, and the design of policies should have this outlook of a national system of care, and that it can focus on the social determinants of health and equity, which is something that we are applying to several lines within the Ministry of Health. Thank you very much. Thank you, Alejandra, for your presentation. Thank you for sharing the advances in Chile and the challenges and the importance of intersectoral initiatives and interministerial in this context of long-term care. Next, we will go with Elena Badillalan from the Direction of Ministry of Health of the Ministry of Health of Costa Rica. I would also like to say hi to Flor Murillo Rodriguez and Melissa Orozco Flores from the Division of Planning, and also from the Ministry of Health of Costa Rica, who are all joining us in this session. Elena, the floor is yours. Good morning. It is a pleasure and honor to be able to share with you the advances, experiences, and challenges that we've had in the long-term care, especially given the populational aging and the situation of people with dependence needs. So, as a first point, we're going to talk about the initiatives that were built to develop a care system. In 2021, the National Care Policy 2021-2031 was made official through a decree, and it was declared of public interest, and it had an action plan looking for the progressive implementation of a care system for people in a situation of dependence. In 2022, we create the National System of Care and Support for Older Persons in a Dependence Situation. We call it SINCA, and I'm gonna base my presentation on this. The goal of SINCA is to optimize existing resource and connect general and specialized services provided by public and private institutions to guarantee the quality of life of the people and the caretakers. The care services are focused on the person and their life course. We have different modalities: residential, home care, personal attention. The system is also aimed at caretakers, unpaid caretakers, the target population, and older adults that are defined as dependent according to our regulation. The SINCA law creates two instances that are important that allow us to provide functionality to the National Care Policy. This is the Technical Secretariat of SINCA, and the main function is to coordinate interactions amongst public and private sectors that are part of the system. This means that they will be following up on technical and administrative processes, financial processes that fall under the policy to respond to the needs of the beneficiary population in an adequate way. This also creates the Technical Commission of SINCA. All these ministries and other public institutions are the ones that form part of the Technical Commission and are currently working on that national care policy. The Ministry of Health that I'm representing is also part of the Secretariat, and we also connect to the Costa Rican social insurance as part of the health system. Decree 44-242 provides a regulation to SINCA. We see how the regulatory framework is giving it shape, and it's allowing for certain functionality to be able to make the participation of institutions binding. That decree officialized Baremo as an instrument that allows us to determine the level of dependence of a person, and it takes certain indicators such as age and mobility and the needs of people. Once you define the degree of dependence that a person has, you assign the timely support and services so that we can care for them. The system has services for each one of the instances. I'm not going to expand on this, but you can look at the catalog of services for people with dependence that we have in our system platform. System platform is called cuidar.com, and you can see the offer of services that each institution, some of these are financial, some are governing the care of people. It can be older people and people with disabilities. We also have the IMAS, the Institute of Mixed Social Aid, and aside from directing the technical commission, it has subsidies for family caretakers. The JPS is the board that manages the lottery system in the country. This is a board that provides support to organizations management, and it also supports them with specific needs such as infrastructure and equipment for those social well-being organizations. And INA is the training entity that collaborates in educating caretakers and those who help older adults or people with disabilities. What are the main achievements that we have? Well, the Commission, through these decrees, we were able to consolidate the technical commissions with the participation of 3 institutions. We also made the Baremo official. So we see that we now have the national record of Baremo. And the Sinurube is a system that includes all of the people that have some sort of social vulnerability that are subject for aid by the state. And it's important that people that are subject to care are also within the system so that we can coordinate the support or aid provided through different institutions. And I apologize for my bouncing slides. 4 institutions are applying the Baremo right now. IMAS, CONADAPIS, CONAPAN, and the municipality of Heredia. And we've had encounters with the public and private sector, and we've made the 2024-2026 action plan official with the institutions involved in the system. The offer of services has been updated by the competent institutions coordination between the Ministry of Health that creates the description of caretakers that are people who are permanently dedicated to the care of older adults or people with disabilities. And this is to create the categories that can be recognized by Sol. This is an initiative of the Ministry of Labor that recognizes companies with best practices, and then the implementation of basic basket for the dependence of the state. Then we have the Cuidar platform that can be found on the site. It has a registry of formal caretakers and a library of all organizations for social well-being. It's interesting, and you can visit the site. Another achievement that we have had is the teleassistance pilot that is being worked through the municipality of Heredia, and they have remote and fixed terminals, and people can activate it with a button in case there's an emergency. There's 24-hour care, reminders of medications, and assistance if there's medical visits, emotional support and guidance to people they can call and ask for help if they have a need, if they feel lonely, and all of this is fully financed by the local government. The equipment and the personnel. The main challenges are public-private connections to expand the services offered, the participation of local governments with local offers for care, creating care ecosystems, the active participation of public and private sectors to guarantee preferential access for caretakers that have those credentials. Opportunities to expand services coverage, to have the necessary budget for this, to have quality services with models that are focused on persons, updating the information system, and then education and awareness focused on rights. And finally, regarding the instrument that, the technical tools that we get from WHO and PAHO today, we see that in practice there are some of these tools, the long-term care, the training of caretakers, recognition of the role of caretakers with a gender perspective, human rights and equity, promoting community leadership and interinstitutionality and multidisciplinary work. We believe all of these are important. We also want to complement Baremo with other tools that are offered within this guide to assess the functional specific capabilities of a person, to design more precise intervention plans. And these protocols can help personalize according to the functional profile of the person. It allows us to personalize care. We also can strengthen the education of caretakers, including technical content to train them
Finally, I'm
in
pleased
ethical,
to
social,
invite
and
Dr. Samir
clinical
Sinha from the
aspects, and this
Sinai
can be
Health and the
incorporated in the
University
education
Health
systems
Network in
of
Canada
Xinca.
to share the
And we
Canadian
can
perspective. Given the
adapt
provincial
this
structure
for
of
day
long-term care in
services
Canada,
and home
Dr.
care,
Sinha was suggested
so
to
that we can
present a
identify
national
gaps and have
perspective
continuous
as a
improvements. And
key
finally,
expert on the
we want to
field.
facilitate
Samir,
interoperability
the
between
floor is
care
yours.
and health, and promote
Thank you very
the
much.
integration of social
I
and health
I
services.
can't share
And
my
think you can use
my
this tool to
slides
better
still, so I'm
connect
not
to
sure.
the Costa
Elena, ¿puedes
Rican
dejar de compartir la
caja
pantalla,
for
porfa?
Social Security.
Perfect.
Gracias.
We currently apply Baremo, but if we apply ICOP in public health, we could
Perfect.
improve
Hopefully you can see my slides, and
Yes.
it's
the
great to be here
activities,
today.
preventive
So
activities,
I'm just going to share a little bit about the
to
experience that
work
Canada
with the
recently had in developing
intrinsic
its new
capabilities
national
of the
long-term
people,
care standard.
depending on their needs. So it would be enriching if we can incorporate this
Now,
tool in a progressive manner.
right now in
Thank you very much.
Canada, its population 65 and older is
Thank you
20%
very
of the overall
much,
population.
Elena,
But we know
for
that within
your
a short
advances
period of time,
for
one in
telling us
4
about the advances
Canadians
in the
will be
national care
65
policy
and
of
older
Costa
as
Rica and
well.
its implementation.
We know that COVID-19 has also shifted our perspectives as a nation. A few years ago, we did some polling around what older Canadians thought about aging in place or where they'd like to receive long-term care services. And you can see that 91% of Canadians of all ages and about 100% of those who are older said they want to support themselves to live safely and independently in their own homes for as long as possible. And I'm sure my colleagues from Brazil, Chile, and other countries online would say that their citizens likely feel exactly the same way. The COVID-19 really shifted our perspectives, but we also have to remember that when we look at how we spend on the provision of long-term care services and the whole continuum that my colleagues have talked about, from home and community care services to long-term care that we provide in institutional settings, you can see that while Canada has a commitment towards providing long-term care services, we're an average spender when you look at the OECD nations overall. You can see that on this slide. The purple bar represents represents average spending across 36 OECD countries. Canada is represented by the maple leaf, just a little bit towards the left, but you can see that we're spending half the amount that some of our other countries are actually spending. And that's a challenge, because when we look at the whole provision of long-term care services, what we talk about is extended and core services. Right now, we have real challenges across the country. And I think what most of my colleagues have talked about already is that when we look at common challenges in long-term care sectors around the world, we know that long-term care has low political priority in most countries. We know the governance of long-term care crosses sectors, ministries, and levels of government. We know that the services have a mix often of public, private, for-profit, and private not-for-profit, and levels of oversight. The funding is typically low, less than 1.5% of GDP, as I showed in the previous slide. There's limited data for monitoring and evaluation, and then we're often seeing staffing shortages, migrant workers, contract workers in this space, in the provision of long-term care services, and compared to other sectors of healthcare, such as the hospital sector, for example, we even find that these staffing shortages are more acute because wages tend to be lower as well. We know that we also have a lack of mandatory infection prevention and control standards, policies, and training. There's substantial mental health pressures amongst long-term care workers, high family caregiver burden, even for those who are receiving long-term care services. And then we know that there's often can be low public confidence in care that's provided in long-term care facilities, but even long-term care sometimes provided in our own homes. So these are common challenges, not just across Canada, but I'd say in many places around the world. And so the provision of long-term care in Canada is quite complicated, because while other countries that have been represented have been able to speak to national strategies and national ways of working, in Canada, while we have what we call our universal healthcare system governed under the Canada Health Act, the first thing to remember is that long-term care service is not enshrined under the Canada Health Act. And so the provision of long-term care services is left up to the individual 13 provinces and territories that make up our country, and therefore coverage levels, standards, service provisions can significantly vary depending on where you live in Canada, and we sometimes call that a postal code lottery of care. We also saw that this varying level of support that we provide to our long-term care services really had significant impact on how we performed as a nation during the provision during the COVID-19 pandemic. What you will see here is this was the average of a study that we did looking at mortality across between what happened to older people living in long-term care settings, for example, like a nursing home, versus older people who might be living in the community in their own homes, versus the population that would be younger than 65 in general, who are community dwelling. The red bars show the people living in long-term care settings, and you could see that overall, there was a 25-fold increased chance of dying if you were living in a long-term care setting on average across these 12 OECD nations. Canada stood out amongst the OECD nations with a 74-fold increased chance of dying, and it really showed kind of the lack of support we were providing for those older Canadians living in our long-term care settings versus compared to those living in the community or people in general in our society as well. So in relation to our performance, especially in our long-term care settings, the federal government in Canada, which again doesn't organize the individual provision of long-term care services, decided that we needed to have new national standards for long-term care. We need to have standards that we would hopefully compel the provinces and territories that are in charge of administering to help reach new national standards for long-term care. And the goal here was to ensure the delivery of resident-centered and high-quality care. The pandemic, as I mentioned, exposed significant gaps in the ability of our long-term care homes to provide high-quality care to residents. And therefore, the National Institute on Aging, which I work with as the Director of Health Policy Research, in partnership with the Standards Council of Canada, the Health Standards Organization, and the Canadian Standards Organization were tasked with developing the new standards. These were led by independent technical committees. These were supported by evidence reviews, surveys, and enhanced public engagement, and over 20,000 Canadians were involved in the development of these new standards. And these new standards were actually launched recently in January 2023. There were two sets of standards that were created. So the HSO and CSA worked collaboratively on developing these two different standards. The HSO standards, which I led the technical committee that was delivering, was looking at what we do inside of homes. So how do we address the delivery of safe, reliable, and high quality services in long-term care settings, whereas the CSA group looked at the design and operation of long-term care homes. So think of it as the software and think of it as the hardware that go hand in hand. What we learned overall was that from the feedback that we received, especially around the type of care that we'd want to provide in our own homes, this is all summarized across three what we heard reports, but we really heard that Canadians wanted the autonomy and choice of resident needs to be respected. They wanted to make sure that residents and their essential care partners were engaged and seen as members of their care teams. They wanted to make sure there was robust safety practices such as infection prevention and control, pain management, the use of least restraints, and appropriate use of antipsychotics as well. And then also the important role for leadership and making sure that the needs of long-term care were supported, including in a number of specific areas as well. And as mentioned, you can read the reports and see the summary of the public engagement that occurred in developing. The overall new National Long-Term Care Services Standard really talks about providing evidence-informed resident-centered care that values compassion, respect, dignity, trust, and a meaningful quality of life. It talks about working in a team-based way to deliver high-quality care that's culturally safe and trauma-informed to meet residents' goals, needs, and preferences. And it really focuses on enabling a healthy, competent, and resilient workforce with healthy and safe working conditions. And finally, upholding strong governance practices and a culture that's outcome-focused and committed to continuous learning and improvement. All of this is completely aligned with the documents that are being released today. And while this standard really focused on care that occurs in long-term care homes, you'll see that it resonates very much so with care in other settings. And currently, HSO is developing a national home and community care long-term care services standard that very much mirrors this document as well. And so right now, for my final slide, can Canada's new standards enable aging in the right place? Well, the CSA standard specifically notes the design elements that'll enable less institutional settings of care and promoting home-like care settings. The HSO standard specifically calls out for appropriate staffing that'll provide long-term care residents with at least 4.1 hours of direct care per day. And it's now being used by Accreditation Canada to accredit 71% of Canada's long-term care homes. So there has been widespread take-up and adoption of these standards as the basis for accreditation. And our federal government has also pledged at least $3 billion to support the implementation of these standards, and also an additional $1.7 billion to improve staffing levels. So I hope this was helpful, and thank you very much for your time.
Thank you very much, Dr. Singha, for your insightful presentation, and to all the country representatives for sharing the progresses and very interesting examples on the implementation of long-term care strategy. Es ahora un honor invitar a la doctora Sonia Café, jefa de la unidad de curso de vida de la OPS-OMS, a moderar la siguiente sesión. Aprovecho la ocasión para agradecer la presencia y colaboración de los colegas de otras agencias internacionales. Estimada Sonia, tienes la palabra.
Thank you, Patricia. Thank you very much. And colleagues, it's an honor to moderate this distinguished panel of representatives from international agencies and organizations. Long-term care, as framed within the decade of healthy aging, emphasizes the importance of intersectoral collaboration and coordination. And this principle, of course, also applies to interagency cooperation at the regional and global levels. We are therefore grateful to have with us today Pablo Ibaran, Division Chief, Social Protection and Health of the International Development Bank, Lorenz Lexartza, and I apologize so much if I'm butchering your beautiful name, Lorraine. You will tell us how to pronounce it. Officer in Inclusive Labor Market Institutions of the ILO Country Office in Argentina, and Ana Yena Nozal, Senior Economist at the Organization for Economic Cooperation
The
and
following session
Development,
will be
OECD.
Welcome.
Each one of you,
will
we
be
invite you to
managed
make
by
a 5-minute
Sonia.
presentation on specific aspects of long-term care. And after the presentations, if there's time, we will open up for some general comments. So we will start the dialogue with the IDB representative, with Pablo. And Pablo, we are asking you to share your perspectives on governance and financing. You have 5 minutes for your presentation. Pablo, the floor is yours.
Muchas gracias y muy buenos días o tardes a
Good morning, and thank you very much. And I thank the PAHO for inviting me to be part of this panel. And yes, I will talk a little bit about financing. I believe that governance is key, because if you don't define it well, the results will be fragmented systems with inequalities in access and deficiencies in quality, and this can be classified in 6 dimensions about the cooperation of different government entities, financing, quality standards, and follow-up systems. And I will focus on the first 3. I would like to start. Well, there's a lot of discussion presently about the regulations for a national policy of care, and this is very important because this provides the basis for general policy. But we cannot forget about how important it is about implementing this policy. Because here you have to guarantee certain standards of quality and the criteria of equality, etc. And there are countries where they start with the regulations and then they develop the policy. And here I want to say that it's very important to develop the policies. And from the bank, we are supporting several countries, Panama, Costa Rica, and the Dominican Republic, especially, well, in developing and implementing these standards. In Costa Rica, we need to establish, we are helping in establishing the regulations for for measuring the quality of services. And there is also the issue of interinstitutional cooperation, and this is complex because there are many actors that are involved at the same time. And we have a lot of participation here, and because of we are here with PAHO, of the ministries of health, but there are a series of different instances that are involved, for example, in Costa Rica. And if you don't achieve an effective cooperation, you will have fragmentation and bad quality results. And there is an interaction between social services and psychosocial services. Both have to do with human rights. So the definition of professional profiles and professional development of workers is also fundamental, and oftentimes there are other institutions that take charge of this part. And there is a fundamental aspect, which is the coordination at central level, but also at regional level, because this is where we identify and offer the services. So the mechanisms for institutional coordination should lead to something concrete to be applied in the territories and the different regions. And we're working with Mexico at central level, but also with Ecuador and Panama and other countries in this sense. And it's important to define a strong leadership, because if the leadership is concentrated in one institution, and then you look for first one among peers, that's a problem. And there are institutions that have a huge budget, but are also dedicated to other things, to other aspects, such as ministries of health. And it's difficult to coordinate all this. It's indispensable to identify the issues and responsibilities. And in each country, this is different. It might be the office of a prime minister, it might be the Ministry of Health or the Ministry of Finance, and you have to all coordinate with all these. And in the different regions, we have seen that a good practice among the different sectors is to establish the leadership role of the care providers. So you have to combine the services of the different institutions. And there are examples, for example, in Japan, France, and the United Kingdom, where you can see how this can work. And then there is the financing, as was mentioned by our Canadian colleague, because if you talk about 1.5 of GDP, it seems small, but in our region, probably we dedicate to much less than that. Uruguay is an exception in this sense. They have a law for the national system of care, but even then, although the service is very good, they invest less than 1%. So the families pay for most of the services through the non-salaried work of women.
The
And this is
importance
not
of a sound
sustainable. We should look
policy
for
and
a
legal framework,
diversification
leadership coordination,
of
creating
financing
fiscal space, and
sources
financial
through
sustainability for long-term
contributions
care. Thank you very much.
of social
Now I would like to
security
invite
or
Larry
financing from the
to
government
share
in
the
order to
ILO
achieve
perspective on
good
workforce. But I
services
insist
of
before you start that you
social
tell me how to
security.
properly
And if
say your
the
name.
services are, if these are social
Hola, buenos días. Es un
services, and
gusto
there's
para mí compartir la mañana de hoy.
a high degree of informality in the countries, then you have to identify various financing sources. And if this is well, it's difficult to work with a fragmented financing. You have to provide regulations, labor regulations, for all of those who work in the system that should be high quality. So these are some of the aspects related to these aspects, and we have to take to hear your comments.
Hi, it's a pleasure for me to share this morning, and I'd like to begin by thanking PAHO and Patricia's team for the invitation. And Sonia, my name is Larite, but I will confess that everyone calls me Lara, and Lara is enough. On my part, I wanted to start by talking about the outlook that we have in ILO to understand care. As you know, the ILO mandate, the International Labor Organization, is directly focused on the labor markets and labor market dynamics and also rights. And the component of care policies that is related to rights and the rights of those who are caretakers, paid caretakers, is an essential component of our outlook. And of course, in the ILO, we also have an outlook that is focused on the way in which unpaid care can impede labor participation and means for livelihood for those who do this unpaid work. Generally, in this case, mostly women. So in this sense, when we talk about the hours of care, this is a common framework that we use to understand policies and care systems. In the ILO, we talk about the 5 hours of care. Aside from the 3 original ones, we want to recognize and redistribute work, and we also want to recompense or pay, and that is through decent formal work with inadequate pay, with adequate shifts, and represent. That is to guarantee the representation of care workers in the sector, also guaranteeing social dialogue and collective negotiations in the sector. When we talk about long-term care, we have to ask, who is doing this work, this care, this paid care, and under which conditions? And what the numbers tell us, the numbers that we have for the region, we can say that we have two elements. We know that in care services, the different services offered by the systems or public policies in the countries in the region, so amongst the different varieties of care services, these are the ones that have less coverage and represent significant challenges in their expansion. We also have a deficit of information when we're trying to understand who is doing this work and how they're doing this work. In general, the pattern of that care labor force in this area relies a lot in paid domestic work, and we know that this is one of the least protected sectors in the labor force. And on the other hand, we still see a lot
Finally,
of
I would like to
opportunities
invite
to move
Anna
forward in the
from OECD
definition of
to take the floor
occupational
and give us a
profiles
perspective
in
on
long-term
person-centered
care.
care. Anna, you have
Meaning, we
5
need to
minutes.
understand the skills that these persons should have. To finish with my intervention, I would like to say that in ILO, we do a global exercise, and this connects to what Pablo was saying about the investment that would be required in other countries in the world and in 23 countries in Latin America and the Caribbean to make this care service universal, guaranteeing labor conditions. For example, considering a minimum wage and sufficient income, and also establishing the limits of people that each caretaker can take care of. And we see that in the region that would imply an investment of 2.4% of the internal GDP. But of course, this will vary depending on the country. So this is all I have to say for now, and I can expand on the next round. I would just show this presentation to give you the context of our practices. So, to talk about person-centered care, we have to talk about the realities, and that is that older people, aside from having long-term care needs, they also have chronic illnesses and health problems, and it is important to see how we can have a system that can consider all of these needs. We currently see that 1 in 7 people in Latin America and the Caribbean needs help with their daily activities. And this is probably not including all the needs for care, given that we're not including some other care needs, such as help to go shopping or cooking. And in comparison, in the OECD, we see that 1 in 4 people has the global long-term care needs. At the same time, what we see is that 1 in 2 people over 65 also has some chronic illness. And in the OECD countries, this population has increased in the last few decades. Now we have more people with chronic needs. On the other hand, in many countries of the OECD, and mainly in the countries of the region of Latin America, there isn't sufficient public coverage for the long-term care needs. We calculate that less than 20% in some cases have this coverage. At the same time, when we talk about integrated care, that is person-centered, in many cases people want to receive that care at home, but this is not always possible because the homes are not adapted for people to go there. In the OECD country, we see that less than 20% of people have this adaptation, so that people don't have to climb stairs or have an accessible bathroom. What does all of this mean? To have more integrated care, on one hand, we have to have a system that allows us to have integrated care through different professionals. We also have to promote self-care and health literacy of people who are older, that is usually lower than the younger population. And here, what we see is that in many countries, they're implementing information campaigns. Sometimes they're general, but there are also web pages such as the one in France for healthier aging. And then there are more specific programs such as programs to reduce falls. And technology can help in self-care so that older people can age with health, for example, using GPS sensors. These can help, and this is something that we've seen in Nordic countries. We also need to introduce new health providers that work between a hospital and home to avoid early hospitalization of persons that leads to loss of autonomy. In the sense, we see that many countries show that home hospitalization reduces the number of people that need emergency care in a hospital and what we call intermediate care. For example, a network allowing people to go back home can help, and this reduces repeated hospitalizations. We also want to promote integrated care where there is a team coordinating healthcare for older people, and we have models such as the one in Japan. It's also been applied in Quebec, Canada, where there is a person that is in charge of coordinating the care, healthcare, and long-term care. Because of time, I'm gonna quickly go over some other needs. When we talk about person-centered care and having a model that integrates not just care, but also an environment that allows people to age at home or within a community. In this sense, adapting homes is very important. And we want to strengthen these care models at home. In Finland, for example, there has been a decision to not have residences. In a few years, all people will receive long-term care at home. But we also see that for older people to remain at home, we also have to reduce unwanted isolation. We are advancing with this by having environments within cities where the places where people live that can be more age-friendly. We want them to have communities that provide opportunities for encounters, and it's also important. Even if people want to continue living at home, we also have to find spaces where people can
Very much. Thank you very much to all our
stay before they
panelists, to
go to a
Pablo,
residence
Lara, Anna, for your valuable
that
contributions.
can provide
In the
services,
interest of
but
time, we have to close now.
that do not
It
isolate
is
people,
now
that
my
people can
pleasure
live
to
with
invite
others. We
Dr.
see
James Fitzgerald,
examples. These are
Director
still
of the
new
Department
initiatives
of
that are very
Health Systems
localized,
and
but we
Services at
have
PAHO
the
for the
example
closing
of Germany.
remarks. Dr.
They
Fitzgerald, the
have
floor is yours.
a federal
Thank you
government
very much,
initiative
Sonia,
where
and a
they're
real
promoting
heartfelt thanks
intergenerational
to all
homes
the participants
that
from
allow young people
WHO,
to
from
have
IDB,
access
but
to
most of all
a house. Sometimes it's difficult
from
to
the
get
member
housing,
states of the
and it allows
Pan-American Health
older people to
Organization
have
for
services such
your active
as
engagement and
help with
participation in this
shopping.
discussion
And then we have
here today.
new
Your engagements really
residential
reflect the
models such as
growing
co-ops
recognition that
or
long-term care is one of the most pressing
smaller
challenges
residences
facing
where
our societies
people
and our
can
health
feel at
systems
home.
throughout the Americas. I think throughout the webinar, we've
This
really
is
heard valuable insights
bringing us
from you all
closer
that
to these models
underscore
of
both the
person-centered
progress made
care.
and the scale of
So
the
with that, I'd
challenges
like to
ahead.
thank you, and
The WHO document that we've launched today
you can
in the
find
Americas,
this
longer-term care for
information
older
on
persons,
our website.
package of interventions for universal health coverage, really offers countries a practical and adaptable set of recommendations to strengthen long-term care within universal health frameworks. We've heard that long-term care really spans a wide range of services, from health and social support to palliative and end-of-life care. It really focuses and requires a person-centered approach tailored to individual needs. And as our populations continue to accelerate exponentially in terms of age, the demand for these services will grow significantly. requiring a real focus on issues around sustainable financing and the development of robust and integrated systems. It's really important, I think, for us as we close to remember that long-term care is not confined to medical treatment. Some services will be delivered in health facilities, but most occur in care institutions, but most importantly in people's homes. The decline in the availability of family caregivers, and mainly women, will continue to place enormous pressure on households and increase the need for formal care strategies. When these needs go unmet, individuals often turn to hospital-based acute care, which is costly and ill-suited for long-term support. We have a framework. The member states of the Pan American Health Organization have adopted a regional policy on long-term care last year at the 61st Directing Council. This was a pivotal step, I think, for the region. It provides strategic and technical guidance to expand and strengthen our strategies as we move forward. And so looking ahead, we do have a unique opportunity to learn from global experiences and invest in quality long-term care, regulation of such, and the development of sustainable financing mechanisms. It also means that we need to enhance our research, develop more appropriate and adaptable guidelines and services according to context that ensure that older persons and caregivers are actively involved in setting priorities. We at the Pan American Health Organization really remain committed to supporting you, our member states, through technical cooperation, knowledge exchange, and the development of integrated people-centered services. But we must act decisively and urgently to build the systems that meet these needs. Once again, thank you all for your dedication, your partnership and commitment. Let us now move ahead forward together to ensure that older persons receive the care and dignity that they deserve. Thank you very much.
Thank you very much for all, and please visit our website for more information on healthy aging and long-term care. Thank you.